everyone. Myself, Dr. Gaurav Gulati, specializes in non-invasive cardiology. I am based in Saharanpur, and today we will talk about the latest update in hypertension. So, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular diseases, which affects 45% in the age group of 40 to 69. So the raised blood pressure is among the most important risk factor for CVDs. CVDs means cardiovascular diseases. So I'll be using CVDs instead of cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension. As in my clinic also, many people are from low socioeconomic background or low literacy rate background. So they are not aware of this high blood pressure. And whenever they are coming in my OPD, so usually they have around 170, 180, but they are not aware of this high blood pressure. So lack of appropriate care through primary care is and poor follow up is there. So that's why. So in India, the prevalence has gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively, as per WHO. Despite that, nearly half of people or 51% of the men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide, as per WHO. International Society of Hypertension has released ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimum and essential treatment paradigm attempt to address the issue, that is resource poor setting. Optimal care refer to evidence-based standard of care, and whereas essential standard refer to minimum standard of care to allow specification of essential standard of care for low resource settings. So the AHA and AACC guidelines has released a scientific statement in 2021 offerings new guidance of management of stage 1 hypertension among patients with low ASCVD risk among low risk as adults with stage 1 hypertension with blood pressure 130 to 139 systolic and 80 to 89 diastolic. Management starts with non-pharmacologic therapy. If BP remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. Thirdly, acute respiratory distress syndrome is potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic BP targets down to 110 to less than 130 range substantially reduced CV adverse event in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Finding from now a second major trial supporting a lower target could unite the guidelines, which among the US professional associate range from threshold to 130 to 150 mm of Hg. With regard to prognostic value of ambulatory BP monitoring and nighttime blood pressure, the European 2018 guidelines in the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on the office BP measurements, but also on the out of office measurements such as ambulatory BP monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurement was associated with greater risk of mortality and composite of CV outcomes. Thus, they may be considered as the most relevant measurement of estimating CV risk. For every 20/10 mmHg increment of BP measurement measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination therapies particularly highlight to improve adherence to the therapy and BP control. I usually also practice this combination therapy in my OPD for BP control. Usually I start with angiotensin receptor blocker plus amlodipine combination, or ARBs plus diuretics, whichever works, which is suitable for the patient. Therefore, the 2018 European guidelines recommended, especially in the context of lower BP target, to start with antihypertensive therapy. The initial fixed dose combination is ACE inhibitor or ARB plus CCP or diuretics. Since early 2018, products containing valsartan have been recalled worldwide. The reason is detection of a carcinogen, namely N-nitrosodimethylamine (NDMA), which has been found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has classified by the WHO International Agency for Research on Cancer to be carcinogenic in human. If 100,000 patients would have received an NDMA contaminated valsartan from Jianghuai, a manufacturing site where the highest level of contaminants was found, every day for 6 years in the total highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could have lead to additional 8 additional cancer cases in 100,000 patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visit to plus 6%. The Hygas study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The Hyga chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening the hypertension therapy exert a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcomes. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV events was significantly improved for the nighttime treatment when compared with awakening treatment. Thank you.